pharmacists are always excited to cook up some thrombolytics. We also have to make sure that they're safe to give per guideline recommendations. Alteplase and tenecteplase would both be appropriate for treating acute ischemic strokes depending on your hospital's formulary, although the blood pressure is concerning. Per the American Heart Association stroke guidelines, thrombolytics have a relative contraindication when the systolic is greater than 185 and or diastolic greater than 110. Hey, what's up guys? Mark at PharmWise. Thanks for joining me on this episode of the Drug Courier Inbox. If this is the first time you're on my channel today, I'm a board-certified emergency medicine pharmacist that makes clinical pharmacotherapy content on the social medias. I often get questions in the comments and compile them into a video series called the Drug Courier Inbox. This gives me an opportunity to have an informal way of interacting with the viewers and also recapping on the most recent posts. Before we get started, I'd really appreciate if you hit the subscribe and notification bell to keep the PharmFacts deposits coming for your drug bank. For the patient cases over the past couple of weeks, and keeping in mind these come from the Metagram patient case series that I post on the social medias, you can find them most easily by going to my links bio at links.pharmwise.com. The link's in the description as well. We've got patients presenting with an overdose, STI concerns in the setting of a pregnancy, left ear pain, a hypertensive coach stroke, and lastly, chest pain associated with an inferior MI. I really do enjoy taking questions from different social media platforms given their differences in user demographics, so please keep them coming in the comments. For the Q&A today, we'll discuss the role of clindamycin as a part of triple combination therapy for treating necrotizing fasciitis, initiating and changing anticonvulsant therapy, and then we'll close it out with whether there's a benefit of tenecteplase over alteplase for treating massive pulmonary embolisms. Let's get right into it. For the first patient case, we have a patient presenting after being found down by their family. There's bottles of empty diphenhydramine, nortriptyline, and buspirone. Which medication should be given for the suspected overdose? Your options are naloxone, physostigmine, none are indicated, or famotidine. Going down the options here, famotidine, a potent alcohol dehydrogenase and CYP2E1 inhibitor that's indicated for toxic alcohol poisonings. Not as much of a suspicion given the patient history here. Physostigmine, an acetylcholinesterase inhibitor that increases available acetylcholine at the synapses to reverse the effects of antimuscarinic overdoses. There is a possibility of diphenhydramine being a part of the ingestion, but the use of physostigmine would be contraindicated in this case since there's the possibility of co-ingested tricyclic antidepressants. In this case, that would be nortriptyline. It's been associated with TCAs and physostigmine to have additive cardiotoxic effects and sudden death. Naloxone, a pure opioid antagonist, knocks off opioids from the receptors in your gut, brain, and lungs. From a textbook standpoint, none of these agents are indicated given the bottles found. However, clinically, I'll buy the fact that you should still give naloxone when a patient's found down and you have a suspicion for an overdose since there's little risk. Continuing on with our patient cases, we've got a 22-year-old female presenting with STI concerns in the setting of being 20 weeks pregnant. Her partner was diagnosed with chlamydia. Which medication should be given? Ceftriaxone, azithromycin, doxycycline, or levofloxacin? I know what you're thinking. It happens a lot more often than you think. Levofloxacin and doxycycline should be avoided in pregnancy when other agents are available. Ceftriaxone's first-line therapy for gonorrhea. Since this patient's partner has an official diagnosis of chlamydia, we should avoid unnecessary antibiotic exposure and not give dual empiric therapy since we have a known bug, which is chlamydia. Doxycycline is the preferred therapy over azithromycin in non-pregnant patients, but in this case, evidence supports the safety profile of the latter in pregnant women. We should be giving this patient azithromycin 1,000 milligrams for one dose and arrangement for test of cure at 4 weeks. Gotta make sure you give the mom and fetus the safest agents. With the next patient case, We've got a patient presenting with concerns of acute otitis externa. What is the primary causative organism? Pseudomonas, Staphylococcus, Streptococcus, or Haemophilus? Conceptually, I like going over acute otitis media and acute otitis externa. Both of these are acute ear infections, but just like any other infection, empiric therapy should be tailored towards most likely pathogens. Be a steward. For acute otitis externa, think outer ear, swimmer's ear. Pseudomonas is known to be more of an aquatic pathogen. For acute otitis media, think middle ear, closer to respiratory pathogens. Commonly associated with community-acquired pneumonia, meningitis, in addition to sinus and middle ear infections, Streptococcus pneumoniae, Haemophilus influenzae, and Moraxella catarrhalis should be on your radar. Make it easy on yourself and think proximity. For the next patient case, we've got a patient coming in with focal right-sided deficits, blood pressures 180 over 117, and a heart rate of 80. The neurologist comes in and calls a code stroke and indicates that thrombolytic therapy is indicated. Which medication should be given? Alteplase, tenecteplase, labetalol, or esmolol. Pharmacists are always excited to cook up some thrombolytics. We also have to make sure that they're safe to give per guideline recommendations. Alteplase and tenecteplase would both be appropriate for treating acute ischemic strokes depending on your hospital's formulary, although the blood pressure is concerning. Per the American Heart Association stroke guidelines, thrombolytics have a relative contraindication when the systolic is greater than 185 and/or diastolic greater than 110. Esmolol is a selective beta-1 blocker that has limited anti-hypertensive properties and more affects heart rate. Labetalol is going to be our best option here as a non-selective beta blocker and is commonly used as an antihypertensive. Consider other agents such as IV push hydralazine and continuous infusion nicardipine or clevidipine. For the last patient case, he's coming in hot. We've got a 69-year-old male presenting with radiating chest pain. The EKG confirms inferior myocardial infarction. Aspirin, heparin, nitroglycerin, and morphine are ordered. Which medication should be avoided? The golden rule in medicine is do no harm. Aspirin, heparin, nitroglycerin, and morphine are commonly ordered together in the emergency department. Yes, our patients complaining of chest pain, and typically we'd use nitroglycerin or morphine. The only two drugs I prioritize in heart attacks are aspirin and heparin initially. These two agents address the underlying problem, which is an occlusion of a coronary vessel from a clot. Nitroglycerin and morphine are primarily for symptomatic management. They've been linked to negative outcomes based on conflicting evidence given their pharmacologic properties. Morphine, by binding to gut opioid receptors, slows down GI motility. This may delay absorption of P2Y12 inhibitors, and these must be taken enterally. On the other hand, nitroglycerin has more of an impact by reducing preload. Inferior myocardial infarctions more point towards right-sided heart ischemia, most oftentimes caused by total occlusions of the right coronary artery. Profound hypotension has been associated with the effects of nitroglycerin in the setting of impaired right-sided heart function. That's a wrap for this episode's post-recap of the Metagram patient cases. I'll take this time and give my page a shout out. If you haven't yet, make sure to check out my website at farmwise.com and take a look at the shop where you can find cool pharmacy and medical related merchandise like this awesome Propofol shirt. I'd also appreciate the support in helping my channel grow by liking the video, commenting below your thoughts and questions, and following on your favorite social media platform. You can find them easiest by going to my links bio at links.farmwise.com. You can also find me on Patreon and support me by donating to my PayPal. Links are below in the description. Let's transition into the Q&A with some recent viewer questions that they left in the comments. Starting with the first question, for this episode's Drug Courier Inbox Q&A segment, it comes from Michael K on Facebook, and it reads, what does the part about clindamycin mean? And this was in reference to my hashtag RX shorts on necrotizing Fasciitis. Necrotizing fasciitis is a severe life-threatening skin and soft tissue infection that progresses into the deep tissue and fascia. Historically, we've used a 3-drug combination therapy that includes a beta-lactam, vancomycin, and clindamycin to empirically treat these infections. They're often polymicrobial, and some organisms are gas-producing, such as group A Streptococcus species, specifically Streptococcus pyogenes. Beta-lactams, commonly used to empirically treat for necrotizing fasciitis, would include piperacillin tazobactam, cefepime, and meropenem. Beta-lactams as a class, and this would include carbapenems, hydrolyze the bacterial cell wall to induce its bactericidal effects. Pathogens such as Streptococcus pyogenes release gas toxins with cleavage of their cell membrane, resulting in a cascade of pro-inflammatory mediators and possibly worsening systemic infections. This is where clindamycin comes in. Mechanistically, clindamycin works as a bacteriostatic antibiotic by inhibiting protein synthesis. When toxins are released with beta-lactam use, clindamycin prevents gas release. With the other antibiotics, vancomycin covers for MRSA, and with our beta-lactam, it should have streptococcal and pseudomonal coverage. The use of clindamycin and vancomycin may be replaced with the use of linezolid based on recent evidence that shows that it can replace its synergistic effects with one agent. The next question comes from Brittany Page 06 on TikTok, and it reads, is it normal to be prescribed lacosamide after levetiracetam after 5 weeks? And this was in regards to my hashtag RxShorts on Vimpat lacosamide. Generally, when initiating or changing anticonvulsant regimens, there isn't necessarily an algorithm that prefers one agent over another based on high quality evidence that shows superiority of one agent over another. When it comes to starting or making changes to anti-epileptic regimens, it's more based on patient-specific considerations. These would include past medical history, organ function, drug-to-drug interactions, adherence, and seizure etiology, amongst others. Certain medications, such as levetiracetam and lacosamide, don't require serum monitoring and are up-titrated based on tolerability and efficacy. On the flip side, levetiracetam has concerns with psychosis and agitation, while lacosamide can be cardiotoxic. The old school agents, phenytoin and divaproex, are more associated with toxicities, drug-to-drug interactions, and adverse drug events. Lamotrigine, topiramate, gabapentin, carbamazepine, brivaracetam, benzodiazepines, zonisamide. There's lots of agents used for treating epilepsy. Seizure management is more dependent on patient response, trial and error, and optimizing different mechanisms of action. For example, divaproex may be preferable given its 2,4 properties and its use in epilepsy and bipolar disorder. The last question comes from @retiher on Instagram, and his question is, any benefit of tenecteplase over alteplase for pulmonary embolisms? This is a great question since a lot of facilities are changing their preferred thrombolytic from alteplase to tenecteplase for treating acute ischemic strokes. Why not save some dollars and streamline things by keeping only one expensive thrombolytic on formulary? Well, saving dollars and streamlining things isn't always what's best for patient care. We've got a lot more evidence behind alteplase in treating massive PEs. On the other hand, there's limited, strong evidence to support the use of tenecteplase for this indication. This is pretty understandable since you have to consider the patient population we're dealing with and their high acuity. Most trials point towards increased risk of harm when utilizing tenecteplase for non-massive pulmonary embolisms. There's one retrospective cohort trial completed in France back in 2019. They evaluated the use of different thrombolytics in treating massive PEs in a mobile ICU. Thrombolytics were associated with increased survivability at 30 days compared to no thrombolytics. However, the study is limited by its retrospective design, small sample size, and the fact that only 74% of patients received tenecteplase. Pretty hard to make a sell on preferencing tenecteplase to place on formulary given the current evidence. Thank you guys for staying to the end of this episode. What's your approach to pharmacologic management of anticonvulsants? Let me know in the comments below. Make sure to follow on your favorite social media platform by visiting my links bio at links.pharmwise.com. And I hope you learned something new.